All right, good morning. Thank you to Stryker. Thanks to Jeff for inviting me again. I think I've been coming to this conference for 3 years now, and definitely an evolution, and we're all learning, like Jeff said, so appreciate everybody's patience. Did I just hit the up arrow? There we go. So a little bit about thoracolumbar fractures. These represent 6% of all osseous fractures. The predominance of them are at the thoracolumbar junction. They're estimated to be about 700,000 a year annually. And as you can see from the statistics, most of them are from T10 to L2, with another large preponderance just below L2, L2, 3, 4. There's a bimodal distribution, but the mean age is 40 years old. So kind of the fractures that we're going to be concentrating on, at least for the first portion of this talk, are really these kind of high energy level injuries in young people, flexion distraction type injuries, burst fractures, rotational deformities, those sort of things. So we're not really focusing on compression fractures. We're not going to talk about cement augmentation, which can be a whole nother discussion. So what are the treatments for these kind of thoracolumbar fractures? Well, traditionally, some guidelines in our management were non-operative care were patients that were neuro intact, they had less than 30 degrees of kyphosis, they had less than 50% loss of height of the vertebral body, they were kind of two-column injuries with an intact posterior ligamentous complex. The operative patients were ones that had neurodeficits that were unstable as per the parameters I just mentioned, meaning greater than 30 degrees kyphosis, etc. Fractures that had dislocations that were mechanisms of significant flexion distraction type injuries with soft tissue components. And then kind of this softer or gray realm with patients that were unable to tolerate bracing or conservative management. So obesity, maybe some visceral injuries, skin lesions, polytrauma where they wanted to try to stabilize the patient and do other procedures or mobilize the patient. Then along came this thoracolumbar classification system in 2005, which it attempted to kind of recategorize these things, not based on those traditional classifications. And the reason they wanted to do that was to give us a prognostic value, to know who we should operate on, who we shouldn't, who was going to do better with surgery and versus non-operative treatment. So this looked at some fracture morphology, it looked at intact posterior ligamentous complex or not, and then neurologic deficits. Those are the kind of three main categories, and it assigns a number score in each of those. And this is how, just the summary of it is that if patients have less than a 4, they usually do better with non-operative treatment. If they have a 4, it's kind of dealer's choice. It's a little bit of a gray zone. If it's over a 4, they usually do better with surgery. But it doesn't really tackle anything about the surgical techniques. Are we talking about anterior column reconstruction? Are we talking about posterior only fixation? Are we talking about fusion, non-fusion, open, MIS? So there's still a lot of controversy with all those topics. So with surgery, what are the pros? That gives the patient stability of the fracture, gives them pain control, earlier mobilization, decreased length of stay in the hospital, decreased pulmonary events. So as we've been seeing with all these other talks, this is true of fracture treatment as well. There's multiple studies showing all this stuff. There was a kind of a meta-analysis that found at least 9 papers citing lower hospital length of stay with fracture fixation. There's less ventilator days, less ICU days, less hospital days. So all that stuff has been proven. And then there's several studies that have shown, because of that, lower cost in treatment by treating people surgically. So somewhere between $40,000 to $80,000 cost savings. So that's great. What are the cons? Well, any surgery, there's cons of infection, blood loss, hypotension during the surgery, further neurologic injury, either from hardware placement or from some further injury to the spinal cord or nerve roots. And then worsening of any comorbid injuries, so if they have a liver laceration or something else, they become hypotensive, you may exacerbate those problems. So this is really maybe where MIS fracture fixation has a foothold over traditional open treatment, is that as we've seen, lower infection rates, less blood loss, so it may really have kind of a niche to play. So there was a paper, I should say that there's very sparse literature overall on fracture, on thoracolumbar fracture fixation, and in particular MIS. And the reason is, like we said, there's not that many patients that have these kind of injuries. And so that most of the reported papers out there are kind of small case series. They're not level 1, level 2, type of evidence. So this was a meta-analysis paper that came out in 2006, was really one of the first kind of large papers to look at everything. And they compared thoracolumbar fractures open versus MIS surgery. And as we would expect, in open surgery, they found that the rates were ranging between 0.71% to 3%, but there were certainly papers that reported infection rates as high as 10%, median blood loss somewhere in most papers around 500 mLs, but up to 1,000 mLs, midline incisions causing paraspinal muscle atrophy, decreased extensor strength, endurance, and kind of chronic pain. So the MIS surgery papers tended to show less blood loss, shorter length of stay in the hospital, improved kind of pain scales postoperatively. So what are the challenges with MIS fixation? Well, you can have some distorted anatomy. The fluoroscopy in the surgery can be difficult, which can lead to complications. And it can, initially anyway, lead to increased OR times and more fluoro use, which I think a lot of the studies will show that kind of learning curve that we talk about improves significantly as you become more experienced, and it really becomes almost equal to open surgical OR time. But initially that's a problem. Another issue is actually the technology itself, is that whenever we're doing these PERC screws, most of the systems use polyaxial screws just because it's easier for us to place the screws into pass rods afterwards. So there's only, as far as I know, really two companies. One has a polyaxial screw that they claim kind of becomes a fixed screw once you pull the tulip up with a kind of device that semi-locks the screw. And then there's one company that actually has a cannulated monoaxial screw. But so that's a problem as far as getting fixation, getting indirect decompression and reduction of the fracture using polyaxial screws. Then there's a whole debate about, well, if you're just going to do PERC screws, are you using this as an internal fixator, or are you actually going to do a fusion here? And now are you going to do a posterior lateral fusion, or are you going to have to start, as we've talked about already, depending on interbody devices, whether these are T-lift devices or vertebral body replacement devices, and then that whole discussion about where the fusion occurs. And then if you're going to use it as an internal fixator, you're not going to fuse. Are you committing the patient to a secondary surgery? Are you going to have to come back later to remove the hardware? So these are all kind of debates and things that are, I think, still evolving in MIS surgery. So I just want to dive into a couple of studies. This one I'll spend a little bit more time on. I thought it was fairly unique because it actually had a reasonably sized group. There were 78 patients. Most of these studies, as you'll see, we'll go through a few more, are kind of maybe 15, 20 patients. So those were 78 patients. And I thought it was also unique that they actually used the same instrumentation in their open surgeries as they did in their MIS surgery. So what they did is they made some kind of small para-Wiltse incision, and they used a monoaxial screw that was not cannulated and put it in and then passed the rod after. So it's really kind of one of the few papers I found that was kind of apples to apples comparison. So they had 78 patients total, 30 they treated conservatively, 23 open, and 25 MIS. They were all neurointact patients, single level fractures between T12 to L2, kyphosis greater than 20 degrees, no other concomitant injuries, no prior back pain or trauma, young patients, no other difference in the cohorts. So this was kind of interesting. I think one of the negatives of this paper is it wasn't a randomized study. Basically, the chief surgeon would go and talk to the patient, and he would tell them about their fracture, and then he'd say, what do you want to do? Do you want to do operative or non-operative? And the patient got to pick. And the non-operative treatment was, if it was deemed an unstable fracture, it was some combination of 3 months bed rest and followed by bracing for another 2 to 3 months. So the average length of stay, and you'll see that later in these patients, was 36 days in the hospital or something like that. If it was a stable non-operative fracture, they were up mobilized right away with a TLSO brace for 3 months. The open, so then the surgical side was either open or MIS, and the way they did that was they basically treated everyone from 2003, 2006 open, and then everyone from 2007 to present in this kind of PERC fashion using the same instrumentation. So I thought pretty good study overall, and that's the instrumentation they used, this monoaxial cam lock. Everyone got 2 levels above, 2 levels below, non-fusion, removal of the hardware at 6 to 12 months, and they had all follow-up over 18 months. So here were the results. In the conservative group, they had 24-degree kyphosis at the beginning, preoperatively. They had 24-degree kyphosis at the end, so no real improvement in the angulation of the fracture. But for most of them, no significant loss. They did say that they had 5 patients that had more than 5-degree worsening kyphosis, and they took them back later and converted them to an anterior column reconstruction surgery. In the open group, they had 26-degree average kyphosis to begin, post-surgical 3.5 degrees at the end of follow-up. So significant reduction in the kyphosis appeared to be maintained over 18 months, even with removal of the hardware. EBL was 550 mLs. One patient, they said, had 3-degree loss of correction, but didn't need any sort of reoperation or anything, 1 infection. MIS group, comparable kyphosis at the beginning and end, much lower EBL, and no complications, no significant loss of correction. And then here was another chart they had on length of time in the hospital. So 36 days for the conservative patients, 4 days for open, 2 days for MIS. So significant savings right there. They had also showed some trends to returning to work earlier and some improvement of ODIs at 18 and 30 months. So I don't know if I'd call that confirmed across other studies, but there's certainly some indication that MIS appears to be as good as open surgery and maybe has some benefits. So we'll just kind of fly through a couple of other studies, showing similar things. 2013, 11 patients posterior PERC screw placement for thoracolumbar fractures, no fusions, versus 27 open screws that did have fusions. No difference in kyphotic angulation before at the end of follow-up. Asia grades were similar. EBL was less in the MIS group. Detractor from this study is it was only a 12-month follow-up, so a little bit short. Another study here, same thing, 10 MIS fixations, no fusion, removal of hardware at 10 months. Other group, 11 open with fusion, no complications in either group. The thing about this study is it was a significantly longer study, 67-month follow-up, so that's like 5-year follow-up. And they found there was no significant difference in the reduction of the fractures or the maintenance of the alignment long-term, lower blood loss in the MIS group. And then here's another study basically showing the same sort of thing, that lower EBL in the MS, 2 infections in the open group. Other than that, seemed to be comparable in the PERC screw non-fusions versus fusions. So I think, that there's certainly literature out there to suggest or support treatment of thoracolumbar fractures with PERC screws, whether you want to do fusion or not, whether you want to take the hardware out or not. I think that's somewhat debatable. Most of these studies they did somewhere around a year, but not everyone. There were other studies where they didn't, and they said the patients did fine. The TLIX score certainly helps. Greater than 4, you should consider doing surgery. And the EBL and hospital length of stay are much shorter in the MIS patients, lower infection rates. And there's some trends that maybe long-term, their ODIs and their functionality is better with MIS. So with that being said, I'd like to talk about 2 cases, and I'll just say that, I'm in a level 2 trauma center, so we don't see kind of hot trauma. I don't see these kind of patients. So honestly, I'm probably not the expert to talk to you about fixation on, thoracolumbar fractures in young adults. But what I do see is like these older ladies, these osteoporotic spines, which I think none of these papers that I saw really addressed those patients. And I think they're much more difficult to treat than the young, 35-year-old guy that you can just put a screw above and below, and then they fracture heels and, whatever. So I'll just show you a couple of cases of my not finest work, and you can see what you think. So it was a 77-year-old lady. She just got up from her couch, said she didn't realize her foot was asleep. She fell on the ground and had significant back pain. Saw her PCP, was given hydrocodone, diclofenac. Comes to the office, maybe, 2-3 weeks out in a wheelchair, just hunched over. She was a smoker, complaining of a lot of low back pain and bilateral L2 radicular symptoms. Now, I'm sorry I couldn't find the pre-op X-ray. I don't know if it was from the family doc's office or something, but this is what her MRI showed. So she's got this L1 burst fracture, retropulse fragments, severe canal stenosis. So what would you guys do with this? She's certainly a TLIX 4 or more. So I think it's reasonable to think about surgery. I guess, you could argue she didn't have any frank weakness, although it's hard to test her hip flexor strength just because of pain. But she certainly has radiculitis symptomology, so you could say that's some sort of neurologic finding. So she could be a 4+ or a 4. She certainly got more than 50% loss of height. Basically, she had 90% loss of height, 25-degree kyphosis from T12 to L2, and 80% canal stenosis. This is where CT looked like. Pretty significant. I don't know if this works. Okay. But anyway, right here, you can see this kind of posterior bony protrusion, retropulse fragments. So this was my plan. This was a case I did actually soon after fellowship. This was about 4 years ago. So I thought, man, this lady's old. She's sick. I'm going to try to be in and out quickly. I don't want to do an anterior and a posterior surgery. I'm going to do posterior fixation. I'm worried about how kyphotic she is overall. So I'm going to do 3 levels above, 2 levels below. I'm going to decompress over the fracture site and try to kind of reach around, tamp some of that bone back to make sure that I'm not relying entirely on indirect decompression by distraction on the screws. So I plan to do like laminotomies bilaterally, or if you want to call it a laminectomy from T12 to L2, and then I was going to lay some posterior lateral fusion mass there. So that was my plan, and put her into TLSO post-op. So intraoperatively, these are how our films ended up. I did 3 levels above, 2 levels below. This is what it looked like from the lateral image, and it's probably a little hard to see. I tried to show kind of the bottom and the top here so you could see it, but probably on, how does this work? Is that it? Okay. So if you can see right here is the top of T12, and if you see where the screw is here in the top of L2, you can kind of see it here. So I think they're relatively neutral, maybe even a little bit lordotic, the end plates. So looks pretty reasonable. You can see our posterior vertebral body, line there looks reasonably well reduced. So I thought, okay, went well. She was out of the hospital in I think 3 or 4 days. She did well with that. She comes back to the office at 4 weeks post-op, and she's pretty happy. Pain's about 50% what it was. We also asked him, how much better, worse, or same are you? And she wrote in 75% improved, even though her pain scale was, 50% improved. She's down to 2 hydrocodone a day. She's not having any significant thigh pain. She's got a little bit of low back pain, surgically expected, and some left flank pain. So I'm thinking I'm pretty happy on the ma'am. But then I looked at her X-rays at the 4-week post-op visit, and kind of seeing this stuff right here at the top of the fusion. It looks like the screws are pulling out. So just if we back up, you can see where the screws were before and now. And you can see, I'm not sure why I left the rods a little prominent. Maybe I was worried. I think I had realized intraoperatively that her bone quality was kind of terrible, and she's very kyphotic up here above, and I thought maybe at some point I might have to extend the fusion, or I'm not sure why I left the rods a little long. But so a little concerning, but it looked like down here at the fracture site, and it's a little hard to see again, but it looked like our end plates are still pretty neutral. So we're kind of maintaining our reduction. She's doing well, so I decided to just watch her. So 6 weeks, I wanted to just kind of see her back quickly. 6 weeks, she's still doing well, but she's losing a little bit of the reduction. At that point, her kyphosis was 17 degrees, but she's not having any radiculopathy. Low back pain is kind of centralizing. She's not having that flank pain anymore. It's just really in the back. So we just basically continue watching her. And she's doing all right. 4 months post-op, she comes back, though, and says, yeah, I'm hurting up at the top of the incision, and it's getting all red there, and I go to church, and I'm sitting in the church pew, and it's like bothering me up here, And I look, and, the skin's kind of starting to erode a little bit. And so I said, all right, well, let's just go in and take out the top screw, and keep 2 above, 2 below, and see how things go. So we did that, and she was doing better at the cranial incision. She's still having a little bit of low back pain, fairly active. She's off all narcotics, was doing all right. And this is what our, X-rays look like after we took out the top screw. So I just went in, I took out the top screw, cut the rods, and did that. So it looks okay, still looks fairly stable across the actual thoracolumbar junction. So I'm kind of holding my breath, and she does all right until about 1.5 years post-op, until she comes back and says, yeah, I'm starting to get that same problem. I'm getting redness and pain up there, and sure enough, now the T10 screws are starting to erode through the skin. So she's still got some low back pain, no radiculopathy, no weakness. She's walking well. She's just really hunched over like this, So I ordered a CT, and it looked like things had fused pretty well on the CT at T12L1, but kind of a paucity of fusion posteriorly at L1-2. So I talked to her and I said, listen, I don't know what's going to happen if we take the hardware out. Do you want me to try to revise the surgery, put new hardware in, maybe use cement augmentation on the screws, maybe do an anterior corpectomy, reconstruct anterior and all this. She's just like, at this point she's getting close to 80 years old. She doesn't want any more surgery. She said, I just, do the least you can and see what happens. So we agreed to remove the hardware, put her in a TLSO for a month or two and just kind of see what happens. At this point I figured, well, it's been pretty stable. We'll see what happens. So, and here's a CT before. So our screws on this image I thought actually looked okay. I didn't see any big like windshield wipering effect around the screws. This is the level above. This is the level below. This is the level where we did the lami decompression. So you can see that, there was a pretty good reduction of the osseous retropulsion. So anyway, so we took all the stuff out. And this is what she looked like a few months after. Not great. So I don't know. I don't have any really moral to the story other than to say, as we do the next case, that I would try to get more robust in my techniques and use things like cement augmentation to help stabilize both screws and inner body placement in these osteoporotic type people. I think these people they do not follow the trends that I was discussing in those earlier papers. Okay, here's another. Yeah, kind of the same. Not any worse, no ridiculous symptoms. She still got pain kind of across the lumbosacral junction. I don't think I mentioned it, but in her early film, she has a little bit of a grade 1 spondy at 5'1" too. So, and she's got some stenosis down there. And she's fine, she gets around. She's still kind of like 20-minute walking tolerance, but she's just so kyphotic in her upper thoracic spine. She just looks terrible, but. You could be part of this, though. Yeah. I think that's success. Yeah, I don't know, No, I appreciate it. I'll take take that anytime. But here's another patient, kind of similarly, 64-year-old female. She had a recent diagnosis of squamous cell lung cancer, 60-pack year history of tobacco. She had a syncopal episode 2 or 3 months prior. She was bending over to get her dog, just fell on the ground, had significant back pain. She was sent to a pain management physiatrist who braced her, gave her some injections, pain meds, trigger points, all this stuff. Nothing really helped. She comes in the office, same thing. Hunched over like this. I can't stand up. I can't walk. I have both my thighs are killing me, And this is what she's got. So she had an L2 burst fracture. She had some workup for Mets and it had all come back negative, including like a cervical lymph node dissection. So I wasn't really suspicious that she had any metastasis, but you never know. So you can tell she's fairly obese. A little hard to see the images here. Here's her MRI. Same sort of thing. L2 burst, retropulse fragments, severe stenosis. I think this axial probably underappreciates it a little bit. So these are kind of her parameters going into surgery. And I said, all right, I've learned something. I'm going to do an L2 corpectomy. I'm going to do an anterior reconstruction. I'm going to put posterior screws to back it up. I'm going to do a posterior lateral fusion. That's my plan. I'm putting a TLSO. So here's some Interop pictures. Did this stuff, put the expandable vertebral body replacement in, and I really did an extensive posterior decompression to make sure that all the retropulse fragments were kind of pulled back anteriorly anyway. I didn't want to rely on just reducing her with the inner body to get ligamentaxis. So, and we put the screws in, and whoops, did I go too far? So anyway, everything looks great. Maybe I'm missing one picture here. But everything looked great at the end of surgery, and I thought, I'm the man, And she did great. She got out of the hospital in a couple days. She comes back at 4 weeks post-op, and boom, subsidence of the inner body graft, which is a common problem with these grafts. There was a great paper by Bill Smith in Nevada, I think in 2011 or 12, where he talked about exactly this problem. And they had, I think, 3/4 or 60% of their patients they did with these kind of expandable grafts. And then the last kind of quarter or 1/3 of the patients they did with grafts that had come out with wider end plates to match kind of the lateral inner body footprints that we use, and they had a significantly lower subsidence rate in those. So what I would tell you is, use the newest technology. I think this is a little bit of that problem. Another kind of tip, if you're going to use these kind of inner bodies, is I probably should not have placed it in such a nice radiographic position of the center of the vertebral body. I should have put it more eccentrically over the pedicle. It probably would not have subsided as much. So kind of looks bad, but overall our angulation still looks pretty good if you draw across the end plates here, right here and right here. We're still pretty neutral. She's doing well as far as pain and everything like that. Her VAS score, again, was reduced about 50%. She's self-rated herself better. She's on hydrocodone, some naproxen. And she was like that for about, 8 months or so, and just kind of steadily improving, standing upright. And these were films I had in the office at 8 months. And I haven't seen her back in a few months here, but she's about a year out. So appears stable, appears to have kind of a fusion mass anteriorly. Maybe a little hard to see here, but I kind of packed allograft and allograft extenders, and also took some autograft from the rib, packed it in the device, and then anteriorly. So it appears to be stable and no real failures yet, but to be seen.
Did you do a poppectomy from the side,
Mm-hmm.
then open it up from the back as well?
Just perk screws in the back. Yep. And then I just put tubes down through the perk screw incisions and decorrugated the facets and packed some bone graft just across the fracture site, just at the level of the fracture, to try to give me some support. Yeah. So I guess, my rule of thumb is either use those newer technology implants if you're going to do this, or, if you're right here doing the corpectomy, you could easily stick a Jamshidi and squirt some cement here into the end plates above and below. That might help kind of reduce your risk of subsidence as well. But I think these patients are challenging to treat, and I don't know if you have the time or patience to give them a full kind of osteoporosis workup before surgery. Usually these patients are coming in, and I'm trying to get them into surgery and get the surgery done in the next week or two, because they're miserable and they're hunched over and they may have some kind of subtle neurologic deficits. So but that would be something you could do. And if you weren't pressed for time, or certainly post-op, you might want to put them on some sort of anti-osteoporotic agent, Forteo or one of those. But I think these are tough patients, and I don't think you should read the literature I presented earlier and just say, I can just put perk screws in all these fractures, no fusion, let them go, and they'll do fine. I don't think that's the case in these older patients with poor bone.
Are you augmenting all your screws now?
No, I don't typically augment the screws. I think it would be nice if we had that option. Like fenestrated screws would be great here, but they're not FDA approved. I can think of one case I did where Interop, I really had trouble with purchase, and I took the screw out, squirted cement in there, and put the screw back in. But typically I don't.
I mean, you can do it. It's just not obvious. You get to tell them that it's off label. I mean, I do it for all my long constructs who are osteopenic or worse. I went through a series of screws pulling out from the top UIV. Then I cemented them in, and then I got a compression fracture above it.
Yeah.
And then I, read Kyle Bosch's study where he said cement UIV +1, but he used the same amount of cement. So then I did that, and I got a compression fracture above that. So I think you're chasing you're just creating a super vertebra. So what I've been doing now is tapering the cement. I use 2 cc's at UIV, 1 cc at UIV +1, and half a cc at UIV +2. And I got 11 patients now. They range anywhere from like 2.2, -2.2, -3.6, and I haven't had a fracture yet.
Mm-hmm.
And it's a pain because you get a little scared because the fenestrated screws would be perfect, but you just have to do it through your Jamshidi, and it gets a little. I usually do 2 levels with one kit, and then the last level with the other kit. I usually do the small kit first because that's the one you have to put a screw in, and it takes a little bit of a fiddle factor because you put the cement in, and then you got to put the guide wire
in, take the Jamshidi,
right?
put the screw in.
And it's literally, sometimes it gets stuck. So it can be a pain, but it's changed my practice ever since. I probably got about 5 or 6 of those patients, and it's miserable. I mean, they are not happy, and then you extend them up, and then I extended them up. The same thing happens there. So this has been like an evolution over the last 5 years, and this tapered cement has really, and granted it's only 11 patients, but so far so good. The only problem is I guess you could just only do it at the top one and bottom one.
Yeah,
I don't have to do it in the middle.
Yeah, I agree. In my experience, I haven't had any hardware failures below
Yeah.
the fractures. It tends to always be above, and I don't know if that's just the patient's overall kind of sagittal balance or what, but so that's why I tend to like do more screws above. Go 3 levels above. But
I think you're probably right at the junction of where the most stress is, right? So you're still lordotic down below, and it's probably part of the reason why it's protected. And up top is either neutral or kyphotic for most of these patients, and that's my opinion as far as the stress, and that's why you're seeing the pull out and or the compression fracture because of the transitions up at the TM junction.
Yep, Niels.
I think these are really complex cases, and we tend to underestimate the instability that we probably don't find there. Like first case you showed, the clawing classification would be grade 3, and I know that in Germany we are kind of aggressive with the indication of anterior reconstruction of the anterior column, etc. And this might be available, but what I can tell you is that since we are so lucky to have in Europe the mandible screws, there's a significant change in these mandible screws. And our experience is that if you use those mandible screws, you can decide within the operation whether the bone quality is good or bad. And if you augment those, you will not find such a hardware fusion in both cases. Also, probably would use index level screws to get more stability since
Right.
the percutaneous cross-connectors are challenging. But these would be the main differences in Europe, I guess.
Yeah, thanks for bringing that up. I forgot to mention that. Yeah, I think that the literature now definitely points to that if you can get some purchase in the fracture level, it's worth it. They show a little bit better reduction in the kyphosis and better maintenance over time. Several studies. So, yeah.
So fenestrated screws are available here now.
Oh, there.
There's a company called Allred that does make them. The only difficulty in using them is that the adapter that connects to the screw has to be perfectly in line with the screw. So if your polyaxial head is slightly off, when you inject the cement, it comes out of the screw.
Nice.
So you have to line it up.
How did those guys get FDA approval? Do you know?
It's not FDA approved. I mean, the company's
It's
going to go
definitely
to.
approved to put something in. It's not different to put cement.
Oh, I see.
A fenestrated screw.
You're walking the line there. I think that company's going to go out of business quickly.
I hope so.
Yeah. Niels again.
There's one more comment. It's very relevant to note that there's a significant difference between men and essentially an advent with the screw in rather than a man through the screw. There's a nice study from Philip Charles from Strasbourg, and he showed that with the augmented screws, if you augment through the screw, it's almost impossible to pull out the screw because you have the optimum position of the cement, which is not true if you inject the cement through the needle first and then
Yeah, it acts as like an extender, surface area extender to the screw. Have you had to revise any surgeries like that? Because that's always a question. Like, what do you do to get the screw out when you have?
no problem at all.
Oh, really?
It's a small trauma.
And it breaks off the cement interface, or the whole cement knobs come out with it, or? Yeah.
In your first group of patients with young, healthy burst fractures, I can see if they have an axial load type of burst fracture. But the inflection distraction, I'm kind of concerned that when you remove the hardware, the ligaments are going to heal in a lengthened position. If they heal at all, I'm surprised that they didn't go on late loss of correction.
Yeah, I mean, I think if you feel like you don't have good bony apposition, that the fracture itself is going to heal, then you may want to augment with some posterior lateral fusion or something like that. I think that's definitely reasonable. I would be hesitant personally to, my experience because of things like this is I don't feel comfortable just putting screws in as an internal fixator and taking them out later without doing some fusion at least over the fracture level. Maybe not at 2-3 levels above. I'll leave those levels alone, maybe take the hardware out later. But I think, at the fracture, my thought is at the fracture level, you need to do some sort of fusion to help augment the anterior column that's going to heal on its own. That's my personal bias. But.